Okay, so I want you to do something for just a second here. Wherever you are, just hold up your hand and wiggle your fingers.
Just a really simple, everyday movement.
Right. It seems so simple, you don't even have to think about it. But I want you to imagine the biological wiring, like the actual physical microscopic cables running all the way from your spinal cord, down your arm, past your elbow, and right into those fingertips.
Because that continuous electrical circuit is exactly what makes that simple movement possible.
Exactly. And that brings us to our mission for today's deep dive. We are looking at this really comprehensive set of medical seminar notes, and they are focused entirely on peripheral nerve injuries.
Yeah, we're basically going to explore exactly how these complex human cables work, how they break down, and really the intricate, often kind of counterintuitive ways the body tries to put them back together.
And the overarching theme here, which I found fascinating, is that form dictates function.
Right, medicine often gets this reputation for being about, memorizing long lists of random symptoms. But if you understand the underlying architectural logic of a nerve, everything else just makes sense.
The specific hand deformities, the surgical treatments, the timelines.
All of it follows perfectly. It stops being a list of confusing clinical signs and basically starts reading like a mechanical blueprint.
I think comparing the body to like a highly advanced electrical grid is probably the best way to approach this. Because when a wire in a city's grid goes down, the consequences for the neighborhoods downstream are incredibly specific.
They absolutely are. So to understand how our biological wires break and heal, we first have to really unpack how they're built.
Okay, let's unpack this. We start with the fundamental unit, right? The neuron.
Exactly. So a single nerve cell has a cell body, which typically sits up safely in the central nervous system, like in the spinal cord. And it has dendrites to receive incoming signals. And then it has the main transmission wire, which is called the axon, and that carries the electrical impulse outward to a muscle or, a patch of skin.
Wait. So if the cell body is in my spinal cord and it's sending a signal to my fingertip, does that mean the axon?
The single microscopic cell?
Yeah. Like, can a part of a single cell actually be 2 or 3 feet long?
It can indeed. It's a single continuous cellular extension. And because it has to travel such a massive distance, the signal needs protection to ensure it doesn't degrade or misfire along the way.
Which is where the insulation comes in. In these peripheral nerves, the axon is wrapped in this protective coating, which the notes say is almost exactly like the rubber casing on a laptop's power cord.
That's a great way to picture it. That biological insulation is called the myelin sheath, and it's actually manufactured by specialized support cells called Schwann cells.
Schwann cells, okay.
Right. But there is a really crucial structural difference between, say, a laptop cord and a human nerve. The myelin isn't just one continuous rubber tube. It actually has these tiny regular gaps stripped right down to the bale wire.
And those are known as the nodes of Ranvier. Which, I have to say, whenever I hear nodes of Ranvier, it sounds like a location in a high fantasy novel.
It really does, but the mechanics behind it are fascinating. Instead of the electrical signal traveling smoothly along every single millimeter of the nerve membrane, the signal physically leaps from one bare gap to the next.
It jumps.
Yes. That jumping mechanism is called saltatory conduction.
It totally reminds me of skipping a stone across a pond. Because the stone spends most of its time flying through the air and only touches down at specific points, it moves across the water much faster than if it had to, push through the water the entire way.
That is an excellent analogy. Saltatory conduction makes the signal transmission incredibly fast and highly efficient.
But not all wires are insulated exactly the same, right?
No, definitely not. We should clarify that. The notes break down peripheral nerve fibers into 3 basic categories. You've got A, B, and C fibers.
Let's map those out for everyone. So A fibers are the thickest, they are heavily myelinated, and they are very fast. These are the main cables handling our major motor commands, like moving your arm, and also sharp, immediate touch.
Right. Then you have B fibers. These are lightly myelinated, and they handle autonomic functions. So those are the automatic systems you don't consciously control.
Like regulating your heart rate or sweating.
Exactly. And finally, you have C's fibers. These are incredibly thin, slow, and completely unmyelinated. No insulation at all. They carry signals for things like deep, aching pain and temperature variations.
So if you accidentally touch a hot stove, the A fibers are the really fast ones that make you instinctively yank your hand back immediately.
Yep.
Well, the C fibers are the ones responsible for that dull, throbbing pain that settles in like 5 minutes later.
That is the perfect real-world translation. The general biological rule here is simple. The thicker the fiber and the more myelin insulation it has, the faster the electrical signal travels.
Okay, so we have the basic wire. But a whole nerve, like the thick ulnar nerve running down your arm, isn't just one single axon.
Oh no, not out.
It's essentially an underwater internet cable made up of thousands of these individual wires.
Hmm.
And the way the body packages them into three distinct layers is brilliant. First, you have the endoneurium.
Endoneurium, yeah.
And this is the delicate inner coating that wraps around each individual microscopic axon.
Right. Then a group of those individually wrapped axons is bundled together into a fascicle, and that bundle gets wrapped in the second layer, which is the perineurium.
And that layer does a lot more than just hold things together, from what I read.
It does. The perineurium actively forms a blood-nerve barrier. It tightly regulates the internal chemical environment of the nerve, keeping toxins and fluctuating systemic chemicals out.
And finally, you take several of those bundles, and you wrap the entire thing in a thick, durable outer trunk called the epineurium.
That is the heavy steel armor of our underwater cable. Nerves even have their own dedicated tiny blood vessels running right through this outer layer.
The vasa nervum.
Exactly. And understanding those three layers, the endoneurium, perineurium, and epineurium, is basically the master key to classifying nerve injuries.
I want to stop and look at that, actually, because the seminar notes introduce two entirely different classification systems for nerve damage. You've got Seddon's system, which has 3 grades, and Sunderland's system, which has 5. Why do we need 2 different classification systems for a broken wire?
It's a fair question. Seddon's system focuses heavily on the broad clinical outcome. He gives us 3 categories: neuropraxia, axonotmesis, and neuromesis.
Okay, break those down.
So neuropraxia is essentially a temporary short circuit. The myelin insulation might be bruised or compressed, often because the vas nervorum, that blood supply, was temporarily squeezed. But the inner wire, the actual axon, is perfectly intact. Recovery is usually fast and complete.
That's the classic my arm fell asleep feeling when you lean on your elbow too long.
Precisely. The next step up is axonotmesis. Here, the inner axon actually snaps, but the outer connective tubes survive. And finally, neuromesis, where the entire cable is completely severed in half.
Okay, so Seddon tells us the broad diagnosis.
Right. But Sunderland's 5-degree system tells surgeons exactly how the architecture has failed. And that is what dictates the actual surgical plan.
So Sunderland just refines the severity by physically counting how many of those structural layers are torn from the inside out.
Yes, exactly. Sunderland's 1st degree is just Seddon's neuropraxia, the bruise. 2nd degree means the axon is broken, but the innermost tube, the endoneurium, is intact.
Got it.
3rd degree means the axon and that inner endoneurium tube are broken.
And 4th degree breaks the middle tube, the perineurium. But I want to pause here, because the notes suggest there is a massive functional difference between a 3rd degree and a 4th degree injury. Why is losing that middle perineurium layer so devastating?
Well, it comes back to that blood-nerve barrier and the organization of the fascicles. If the perineurium breaks, that protective barrier fails. The internal environment just becomes chaotic.
Right.
And more importantly, the pathways that guide the microscopic wires are now completely breached. So when the nerve tries to regrow, the wires don't just stay in their designated lanes, they can actually cross over into neighboring bundles. A motor nerve fiber might mistakenly grow down a sensory channel.
Oh, wow. So the brain sends a signal to, say, move a finger, but because the wire got crossed during regrowth, the patient just feels a tingling sensation on their skin instead of actually moving the muscle.
That is the exact problem, yes. And then Sunderland's 5th degree is the complete transection of the outer trunk, the epineurium. So what's fascinating here is Sunderland's grading isn't just academic trivia.
It's practical.
Very practical. If those outer tubes are intact, the nerve had a physical pathway to heal itself naturally. If they are severed, the structural roadmap is lost. The patient will literally never regain function without surgical intervention.
Which brings us to a process that completely shifted my understanding of biology. Let's say a nerve is severed. The cable is cut. The body doesn't just sit there. It actively prepares the site for regrowth through this process called Wallerian degeneration.
Yes. When the axon is cut, The entire segment of the wire that is distal to the injury, meaning the portion that's separated from the main cell body heading further down the arm, it loses its life support.
Right, because the cell body's up in the spine.
Exactly. But it doesn't just quietly fade away, it actively disintegrates. The broken axon and its myelin insulation break themselves down into fragments. Then, immune cells called macrophages actually arrive on the scene to aggressively clear away all the cellular debris.
It's like a controlled demolition.
It really is.
But why go through the effort of destroying it? I mean, why doesn't the body just try to patch the two broken ends together like superglue?
Because the distal portion is fundamentally dead without the cell body's continuous supply of proteins and nutrients. Attempting to attach to a rotting structure would be useless.
That makes sense.
The body recognizes that it must completely demolish and clear out the ruined highway before it can possibly pave a new one.
Okay, so once that debris is cleared, the Schwann cells, the ones responsible for making the insulation, they shift their behavior. They stop acting like insulators and actually line up end to end to form these hollow, microscopic guide tubes.
Yes.
The notes call them the bands of Bungner. They're literally constructing an empty tunnel, just waiting for the new nerve to grow into it.
And then, up at the surviving stump near the injury site, the axon begins to sprout new growth cones. It chemically searches for the entrance to that hollow tube, and if it finds it, the axon starts growing down the tunnel toward the muscle.
But the math of this regrowth rate is just daunting. It grows at a rate of exactly 1 millimeter a day.
Roughly an inch a month.
Right, so if a patient slices a nerve up near their shoulder, and it has to regrow all the way down to the fingertips.
You are looking at a process that takes well over a year, maybe 2, of just waiting.
That is wild, and that assumes everything goes perfectly. If those sprouting nerve fibers miss the entrance to the bands of Bungner, they have nowhere to go. They just continue to multiply and spiral out of control, tangling up into a dense, highly painful ball of raw nerve endings known as a neuroma.
They do. But if the nerve does find the tube, doctors can actually track this slow 1 millimeter a day journey from the outside. They use a technique called Tinel's sign.
Oh, the tapping thing.
Exactly. Tinel's sign is an incredibly elegant clinical tool. If a doctor lightly taps along the anatomical path of the nerve on the patient's arm, the patient will feel absolutely nothing over the dead portion.
Because it's dead.
Right. But the moment the doctor taps the exact spot where the growing raw tip of the nerve currently is, the patient feels a sudden burst of tingling or electrical shock.
It acts as a physical, real-time tracker of a microscopic growth front. That is amazing. As the months pass, the doctor can literally map that spot of tingling, moving further and further down the arm.
It's brilliant. Now that we understand the underlying mechanics of injury and recovery, we should probably look at how this presents clinically. The notes focus on the arm, which is powered by 3 major nerves: the radial, the ulnar, and the median.
Let's start with the radial nerve. The radial nerve is considered the great extensor. It powers the triceps and basically all the muscles on the back of your forearm that allow you to lift your wrist and straighten your fingers against gravity.
If the radial nerve is compromised, the hallmark sign is called wrist drop. You ask the patient to hold their arms straight out, palms down, and the affected hand simply hangs downward limply. They physically lack the wiring to lift it.
But the location of the injury changes the presentation, right? The notes highlight Saturday night palsy versus crutch palsy.
Yeah, so Saturday night palsy is a classic compression injury at the spiral groove, which is midway down the humerus bone in the upper arm. It gets its name because it frequently occurs when, well, an intoxicated person falls asleep with their arm draped heavily over the hard back of a chair.
Ouch.
Yeah, the nerve is literally crushed against the bone.
But because the injury is halfway down the arm, the branch that feeds the triceps muscle, which sits higher up, is totally fine.
Correct.
However, if the injury is higher up in the armpit, say from leaning heavily on poorly fitted crutches, that's crutch palsy. And in that case, the signal is cut before the triceps branch, so the patient loses the ability to extend their wrist and their elbow.
It is a perfect example of tracing the wire back to the source. Let's move to the ulnar nerve. If the radial nerve is the brute force extensor, the ulnar nerve is the fine tuner. The notes refer to it as the musician's nerve.
Right. It runs right behind the medial epicondyle at the elbow, what we commonly call the funny bone. That passage is the cubital tunnel.
Yeah.
It then travels down to the wrist, where it passes through another tight space called Guillon's canal. And the ulnar nerve primarily controls the intricate, intrinsic muscles in the hand, specifically powering the ring and pinky fingers.
So when it sustains severe damage, it results in a really dramatic resting deformity called the ulnar claw.
Describe the claw for us.
With the ulnar claw, the knuckles of the ring and little fingers hyperextend backward, and the finger joints curl sharply inward. It is a very stark, visible resting posture.
And doctors test for ulnar nerve function using Froment's sign. I'd actually encourage you listening right now to try this motion. Take a piece of paper and pinch it tightly between the side of your thumb and your index finger, exactly like you are gripping a car key.
In a healthy hand, the thumb stays relatively straight because a specific muscle powered by the ulnar nerve pulls the thumb solidly against the index finger.
But if the ulnar nerve is damaged, that muscle is paralyzed. So when the doctor tries to pull the paper away, the patient's body subconsciously compensates. To keep its grip on the paper, the body recruits a different muscle fed by a completely different nerve, causing the tip of the thumb to bend sharply inward.
And that sharp flexion of the thumb tip is Froment's sign.
It's a brilliant biomechanical workaround by the body, really, but an immediate red flag to a physician that the ulnar nerve is offline.
Right. Now we arrive at a concept called the ulnar paradox.
Here's where it gets really interesting. I want to spend some time here because it seems to defy basic medical logic.
It really does at first glance.
Usually a higher, more proximal injury on a nerve results in a more severe deformity. But the ulnar paradox states that if you cut the nerve high up at the elbow, the visible clawing of the hand is actually less pronounced than if you cut it lower down at the wrist. Why would a worse injury cause less of a visible deformity?
I know, it sounds contradictory until you look at the actual musculature of the forearm. The ulnar nerve doesn't just supply the small muscles in the hand. On its way down, it also supplies a powerful muscle in the forearm called the flexor digitorum profundus, or the FDP.
FDP, right?
This is the heavy lifting muscle you use to tightly curl your fingers, like when you are carrying a heavy grocery bag by the handles.
Okay, so there's a heavy forearm muscle and then the delicate hand muscles.
Exactly. If you sever the ulnar nerve low down at the wrist, only the delicate hand muscles are paralyzed. But that powerful FDP muscle in the forearm is still receiving its signal from above the cut. So without the hand muscles to balance it out, the FDP forcefully pulls the paralyzed ring and pinky fingers into a tight, severe claw.
Okay, I see.
But if you sever the nerve high up at the elbow, you paralyze the delicate hand muscles and you cut the power to that heavy FDP forearm muscle. Because the muscle responsible for actively pulling the fingers into a claw is now offline, the hand actually sits much flatter.
The true paradox occurs during recovery, right? As a high elbow injury slowly heals at 1 millimeter a day, the forearm muscle regains its connection first because it is geographically closer to the injury site.
You've got it. So as the heavy forearm muscle wakes up, it starts pulling on the fingers again. But the small hand muscles are still dead because the nerve hasn't reached them yet.
Wow. So as a patient heals, the visible clawing of the hand actually gets dramatically worse before it gets better.
Precisely. The recovery process actively creates the symptom.
That is a phenomenal example of biological mechanics in action. Let's look at the third and final major wire, the median nerve. The notes call this one the laborer's nerve.
Right. The median nerve supplies the bulk of the flexor muscles in the forearm that you use for coarse, heavy gripping. In the hand, it supplies a very specific group of muscles at the base of the thumb and palm.
And medical students memorize these using the acronym LOAF, right?
Yes. Lumbricals, opponens pollicis, abductor pollicis brevis, and flexor pollicis brevis.
And this is the nerve famously associated with carpal tunnel syndrome, where the nerve gets compressed as it passes through that tight ligament tunnel at the wrist. That causes the classic numbness and tingling in the thumb, index, and middle fingers.
But a severe injury to the median nerve higher up in the arm causes a highly specific clinical sign known as the hand of benediction.
Now, the seminar notes specifically warn against confusing the hand of benediction with the ulnar claw. They might look similar to an untrained eye, but they represent entirely different mechanical failures.
They do. The distinction really lies in active versus passive presentation. Remember, the ulnar claw is a resting deformity. The patient is doing nothing, and the hand just sits in a claw. The hand of benediction is an active sign. It only appears when you ask the patient to perform an action.
So if the doctor says make a tight fist, the patient attempts to comply. The ulnar-powered ring and pinky fingers curl down perfectly fine. But because the median nerve is severed, the flexor muscles for the index and middle fingers are dead.
Right, so those first two fingers remain pointing straight out, resembling a clergyman giving a blessing.
Hence the hand of benediction. And the median nerve also controls the thumb's ability to swing across the palm to touch the other fingers.
Yeah.
Right. A movement called opposition.
Yes. When the median nerve is completely lost, those muscles at the base of the thumb waste away. The thumb falls back to lie flat in the same plane as the rest of the fingers, creating this flat, simian appearance known as an ape thumb.
There is one deeply specific branch of the median nerve mentioned here that I found amazing, the anterior interosseous nerve. If just this deep branch is injured, you actually lose the ability to make an okay sign.
It's true.
If you try to touch the very tip of your thumb to the very tip of your index finger to make a perfect circle, you need that nerve to flex the final joints. If it's dead, the finger joints collapse, and the pads of the fingers just press flat against each other in a pinch rather than forming a circle. It's known clinically as Kilo-Nevin syndrome.
It really is remarkable to think that a microscopic biological wire controlling the flexion of a single millimeter-wide joint has an entire named medical syndrome attached to it. It highlights how utterly precise this internal grid really is.
So what does this all mean for diagnosis? If a patient walks into a clinic presenting with an ape thumb or a wrist drop, how does the medical team actually evaluate the extent of the damage? The notes mention that autonomic signs are often the first objective clue.
Yes. Remember those thin B fibers that control autonomic functions like sweating? When a nerve is cut, it literally stops telling the sweat glands in that specific area to fire. So a doctor can feel the patient's skin, and a distinct patch of dry, non-sweating skin maps perfectly to the territory of the severed nerve.
That's incredible. Following that, they conduct a rigorous clinical exam. They evaluate motor strength using the MRC scale, which ranges from 0 to 5. 0 means absolute paralysis, like no flicker of movement at all.
Right. And a 3 means the patient can move the limb against gravity, but not against any actual resistance from the doctor. And then a 5 is completely normal strength.
And they match that with a sensory evaluation on the S scale, from S0 to S4. S0 is complete numbness. As they move up the scale to S3 and S4, they use tools like a 2-point discrimination test.
Right, pressing 2 tiny, blunt prongs against the fingertip to see if the patient can feel them as 2 distinct points, or if the damaged nerve just blurs them into one single sensation. S4 means perfect, normal sensation.
Once the physical exam is done, they want to look at the electrical signals themselves using electrodiagnosis, which involves nerve conduction studies and an EMG. But here is the protocol that completely baffled me at first.
The waiting period.
Yes. The notes stress that examiners love to test medical students on this specific rule. If you sustain a severe nerve injury today, the neurologist must wait 2 to 3 weeks before they can run these electrical tests. If my arm is hanging limp right now, why on earth are you telling me to go home and wait 3 weeks for a diagnostic test?
I know, it feels like a massive delay in care, but it goes right back to the Wallerian degeneration we discussed earlier. Think of a severed axon like a downed power line lying in the street.
Okay, down to power line.
Even though that power line is completely detached from the main power plant, the physical wire lying on the ground might still hold a residual electrical charge. In the human body, the severed distal axon still contains ions. It still has a resting membrane potential.
Oh, I see.
So if a neurologist runs a localized electrical current through that disconnected piece of nerve on day 2, the muscle might actually twitch.
So the test would show a false normal. It would literally look like the wire is functioning, even though it is completely detached from the central nervous system.
Precisely. It takes 2 to 3 weeks for the Wallerian degeneration process to physically dismantle and rot away the distal wire. Only after that controlled demolition is complete will the EMG show the true electrical silence of a dead nerve. The diagnostic testing must respect the biological timeline.
That structural logic is just so satisfying. So once the severity is confirmed, the treatment plan is entirely dependent on which anatomical layers are broken. If it is Seddon's neuropraxia or a low-grade Sunderland injury where the inner tubes are intact, the treatment is conservative.
You utilize watchful waiting. The patient undergoes intense physical therapy to keep the target muscles active so they don't atrophy, and they wear specialized splints to ensure the hand doesn't freeze into a permanent claw posture while they wait for the nerve to regrow at that painfully slow 1 millimeter a day.
But if the nerve is completely transected, a 5th-degree Sunderland injury, the patient is heading to the operating room. And timing dictates the surgical approach. If it is a clean, sharp laceration, perhaps from a kitchen knife or a piece of glass, surgeons aim for a primary repair within 72 hours.
Right. They use microscopic sutures to stitch the outer epineurium trunk back together, ensuring the ends meet with absolute zero tension.
Zero tension is key. Conversely, if it's a messy injury, like a severe crush injury from machinery or contaminated wound, they actually wait. They allow 3 to 4 weeks for the crushed tissue to fully declare itself, clean out the necrotic debris, and then perform a delayed repair.
But what happens if the injury destroyed a large section of the nerve and there is a physical gap between the two severed ends?
You can't just stretch it right.
No, you absolutely cannot stretch a nerve to close a gap. If there is tension on the line, the repair will fail. To bridge the defect, surgeons harvest a non-essential nerve from elsewhere in the patient's body.
Usually the sural nerve, right? A sensory nerve located in the back of the calf.
That's the most common one. You sacrifice a small patch of skin sensation on the leg to use that nerve as a sort of biological extension cord. It is grafted into the arm to provide a physical tube for the regenerating axons to grow through.
And as an absolute last resort, if the nerve is permanently lost and the muscle has irreparably wasted away, surgeons perform tendon transfers. They literally detach the tendon of a still functioning muscle powered by a healthy nerve and reroute it to anchor onto the paralyzed finger or wrist.
They borrow a working pulley system to perform the job of the dead muscle.
Wow. The entire spectrum of surgical strategy rests fundamentally on understanding exactly what structural layers of the cable are broken and knowing how the body naturally attempts to bridge that biological gap.
Right. When the underlying biology is understood, the pathology basically transforms from a mystery into pure mechanical logic.
We started this exploration just by wiggling our fingers, and we have ended up mapping out the microscopic tailoring of biological extension cords. It all reinforces that central theme, that medicine is not a random collection of memorized syndromes. If you truly grasp the architecture of the wiring, the subsequent short circuits make complete logical sense.
Absolutely.
I want to leave you, listening right now, with one final thought to consider.
Yeah.
We spent a lot of time discussing how a severed nerve naturally searches for those microscopic bands of Bungner to guide it home, locked into this painstakingly slow biological speed limit of 1 millimeter a day. But consider the trajectory of bioengineering. What happens in the near future when we can routinely 3D print synthetic, biocompatible guide tubes? What if those artificial tunnels are infused with targeted growth factors that dramatically accelerate that biological clock? Could the devastating permanent paralysis of a severed nerve one day be cured, not with a complex multi-stage surgery and years of waiting, but with a simple printed biological bridge that regrows an arm's function in weeks?
It's an incredible possibility.
Think about that complex biological machinery the next time you wiggle your fingers. Thanks for joining us for this deep dive.